Hi, I'm Dr. Scott Jensen, and I am not exaggerating when I tell you, if you're a patient, your doctor, your insurance company, your clinic, your hospital, we can all get paid more if we make you sicker. And I think you need to understand that. I've thought about doing this video for some time, but I'm a little nervous because I don't really want to get myself in any more hot water than I already am in regards to having governmental and public health agencies weaponized against me. But I'm going to say it again. If I make you sicker, I'll very likely get paid more. And I want to just unpack this a little bit. So I'm going to talk sort of quickly. I'm not giving you medical advice. Please see your own doctor for that. And my name is Dr. Scott Jensen. And I think this is important. So I've been getting a lot of patients lately. They've been coming in and they say, "Hey, Dr. Jensen, a nurse stopped out at my house the other day and had me do a bunch of different things. What's that all about?" And I would hold up some papers and I'd say, "Oh, I've got it right here." So here's one patient. We'll just call him John Doe to de-identify him. So someone calls him and says, "We'd like to come to your house and just do sort of a house call at your house. And so very convenient for you." They don't tell the patient, John Doe, "And if you let me come in your house and get in your front door, then I'll get paid $100 or $150 or $200. And if I can complete this house call survey on you, then my employer will get paid more, potentially by the government or by the insurance company, depending upon who's who." So on this one here, this was John Doe, and he had this person come out, and there were all kinds of recommendations. But it's a 7-page report I got. One of the things that was, I guess, quite important was John Doe was asked, "Do you feel physically and emotionally safe where you are currently living?" And he said, "Yes." Well, now this is a person who's in his 8th decade of life, so I would hope that he would feel safe and things like that, but I guess we're going to go out and query the world. The findings of his mini house call were that he's at a moderate risk to a high risk of falling, that his sensation in his feet is impaired, indicating a problem in neuropathy. He didn't realize that he was morbidly obese due to excess calories, but he is. He doesn't use a CPAP machine, but he does have obstructive sleep apnea, along with a multitude of other diagnoses that he didn't know he had. And he also now can be classified as having peripheral vascular disease because of one of the tests that was done when this nurse was there. He was advised that he's supposed to take a tetanus shot, a Prevnar 15, a Prevnar 20, colorectal cancer screening. He's also supposed to see me for advice regarding the use of the various over-the-counter chemicals and bad habits. So I added it up. And if John Doe comes to me and does all the things that he's been told to do based on this, it'll probably come to be somewhere around $5,000 to $10,000 without breaking a sweat. Okay, so why is this being done? This patient's on Medicare. His insurance company will get paid more by Medicare if this patient is seen as more sick. There's all kinds of incentive plans being doled out by insurance companies and governments, government programs, to clinics and providers and healthcare systems. For instance, one of them that you may have heard of is if a clinic can hit a certain threshold level of patients taking a certain kind of vaccine, they get paid a chunk of money for each one of those patients that took the vaccine. So it's not uncommon to have like an influenza vaccine incentive program, and say you have 1,000 patients that could potentially qualify. Well, if you could hit, say, 60%, you might get this amount of money per patient. If you can hit 80%, they'll give you this much. Literally, doctors can get tens and tens of thousands of dollars on an annual basis for an incentive program as simple as that. Here's another one. If we can call you diabetic based on some parameters, even if we're not treating you with the medication or didn't really do anything for you, if we can call you diabetic and we do a test called an A1C. Now, if we do an A1C and we get a 6.8 reading, that allows us to call you diabetic, even if we don't do anything for you. And when a person has diabetes, generally a doctor or a clinic will get a good mark if they can keep that person's A1C less than 7.5, sometimes less than 8, sometimes less than 7. But if you can call someone a diabetic with an A1C of 6.8, you don't have to do anything. You just get to put them down as a diabetic, and they'll count as a good patient for you because you've gotten their A1C to less than 7 or 7.5. So all of a sudden, you've got this bizarre incentive to call as many of your patients as possible as diabetics. Here's another monitoring program. And this one, we'll call this patient Jane Doe. Now, Jane got paid somewhere around $100 to go to this physical place and have some tests done. So Jane's 90, just about. Blood pressure comes back. She goes to this place. Her blood pressure is 135 over 60. 135 over 60. So she is advised, that's not healthy. Your blood pressure is too high. You need to have your blood pressure checked within 2 months by a physician. Don't you wait 4 months when your annual physical is going to take place. You got to see a doctor in the next 2 months because you're